Welcome back to The Thinking Mind, a podcast all about psychiatry, psychology, therapy, and much more. One of the problems clinicians often face in the world of mental health is a lack of options. Often when treating our patients, we feel we need more tools in the toolbox. And on this topic, today I'm with my co-host, Dr. Anya Borissova, and we're in conversation with Daniel Månsson. Daniel Månsson is a clinical psychologist and the founder of Flow Neuroscience. They are a medical device company which produce headsets for what's known as TDCS, also known as transcranial direct current stimulation. These devices have gone through the regulatory processes and have been approved for the treatment of depression in the UK, the EU, and other places. Transcranial direct current stimulation is related to transcranial magnetic stimulation, which you may have heard of. Magnetic stimulation is typically used in a hospital or clinic where you can have medical supervision. It's thought to be more intense and generally used for more treatment-resistant patients, but the same underlying principle underlies both of these treatments. You're stimulating the brain to try and get a part of the brain that's less active and make it more active. So today you're going to hear us discussing both TDCS, direct current stimulation, and TMS, magnetic stimulation. And with Daniel, we also discuss what may be going on at the brain level in certain cases of depression to warrant these kinds of treatments, different pieces of research that have looked into the effectiveness of TDCS. Anya and I already did a deep dive into the Nature article, which was sponsored by Flow and which shows the effectiveness of this treatment. If you want to check out the deep dive into that paper, check out episode 139, which we released last month. We also discussed today the challenge of maintaining the ethical considerations when running a company that sells medical devices. Of course, there's a lot of ethics there. And we also discuss how these devices may complement psychological treatments like psychotherapy and open questions Flow would like to answer when it comes to future research. Just a note at the top of this podcast, we can declare we have no conflict of interest here. We're not affiliated with this company in any way. Personally, I feel that although one has to be careful about how one goes about it, I do welcome a kind of entrepreneurial spirit when it comes to trying to tackle some of society's biggest problems, and that does include mental health. We talk about a few different studies on this podcast, and they're listed in the description. Daniel also mentions that some studies have been done within the NHS on these headsets, and I gave an example of that also in the description. The NHS has been using these devices across 6 NHS trusts, so interesting to show what that research indicates. We hope you enjoy. Thanks for listening, and now here's today's conversation with Daniel Månsson. Thank you so much for joining us.
Thank you so much for inviting me.
To start, it would be great to get a sense of the story behind Flow. How did it start? What were its origins?
Yeah, so it started about 10 years ago when I took the decision. I was a clinical psychologist, still am a clinical psychologist, but I was practicing back then up in Norway. And a friend of mine, Eric Wren, also a Swede, came back from California after joining that company as a machine learning researcher. He's a computational neuroscientist. So he came home from the US, and we decided that we wanted to start this company. And if I'm backing up a little bit even further, I did my master thesis as a psychologist on this technology that we're working with, TDCS, and that we can talk more about. And I was very intrigued by that technology and what it could do. It had a very good safety profile, and efficacy results were coming out and so on. So we decided that we were going to do something together to add another tool in the toolbox, not to replace anything, but more like adding a tool in order to treat depression.
And before we get into TDCS itself, could you explain a little bit about the science that informs TDCS and transcranial magnetic stimulation? What does the science say about depression that then leads us to interventions like TDCS and TMS?
Yeah, so I think if we start with the main hypothesis of brain stimulation, at least with these that you mentioned, TMS and TDCS, trying to get the neurons to fire in a certain way. And then there are different strengths of the stimulation. In these cases, TMS is stronger in the sense that you can get the neurons to fire right away, whereas TDCS is a nudge, a push towards the firing point of the neuron. So you apply the current, you get the neurons to fire, and if you do that in a certain way, you can get behavioral outcomes in the end. That's a very simple explanation of it, because the brain is communicating, as you of course know, with chemicals and electricity.
And is this a specific part of the brain we're talking about that we're targeting with these kinds of interventions?
So normally, or the standard protocol would be that you're trying to activate or increase the activity of the neurons in the left dorsolateral prefrontal cortex. So that's a mouthful, but it's an area where I'm pointing basically right now, where you have a bunch of different effects if you try to do that. So you can go deeper into the brain if you want to be more advanced, if you want to do implants, for example. But if you want to do these surface kind of stimulations, then you would normally go for the left dorsolateral prefrontal cortex with the anode, with the activation, and then you would do the cathode over the right dorsolateral prefrontal cortex in order to decrease the activity there.
And I can imagine someone listening to this and maybe not having a background in psychology and psychiatry and thinking, okay, if there's a part of the brain that's underactive and this may be associated with depression, then this must mean, depression is a kind of biological entity, if you like, or biological process, fundamentally biological. But is it fair to say that it's still kind of mysterious what might cause a part of the brain like this to be underactive, that it's likely to be some combination of biological factors, psychological, social, genetic, stuff like that?
Yeah, I wouldn't say mysterious. I would say that we don't know yet exactly what the mechanisms are. And in my world, the way I understand the human condition, there is a biological basis for everything. So the psychology is built on the biology. But of course, it might be easier to describe certain things in a psychological terms. But in the end, in my world, everything is biological. But that's more of a philosophical discussion, I guess. So, but of course, there are many different ways to approach what becomes depression, or how to describe what becomes depression in the brain. So you mentioned genetics and psychology and biology. So yeah, I would agree with that.
And then I guess like social forces as well, things like poverty, coming from a disadvantaged background, abuse, various forms of psychological stress.
Oh, yeah.
And so, I mean, it'd be interesting to see how our thoughts differ on this. But the way I've kind of landed on the phrase I really like is biological level of analysis. So when we see there's a part of the brain that seems to be underactive and that's associated with depression, there could be lots of inputs causing that ultimately. And at the biological level of analysis, we can see this happening. And of course, that implies that we can also treat it at this level and at other levels as well. And I think it's nice that I think you mentioned before that you see these kinds of treatments, TMS and current stimulation, as well as more like complementary treatments. Is that right?
Yeah, we do. We see all kinds of treatments as being a part of the toolbox, as I said before, and you can address them in many different ways. And then certain treatments are more effective than others, I believe. But they obviously complement each other rather than...
Getting onto like the stimulation treatments themselves, I'm totally ignorant of the history of this. Does magnetic stimulation predate historically direct current stimulation?
Yes, normally. So normally you would say that in the beginning there was ECT, and you used the convulsive therapies in order to have a certain mechanism of action on the very severe cases. And you still use, as you also know, of course, the ECT, and it's a very effective treatment in psychiatry. I'm not sure about the exact year, but TMS came after that, came first. It was approved first all over the world, and it's been researched a little bit more. It's in certain guidelines, and it's reimbursed in certain countries and so on for severe, often treatment-resistant depression. And then in the beginning of the 2000s, I would say, some serious research started coming on these weaker electrical stimulation techniques, such as TDCS.
What are the main risks of magnetic stimulation, like common risks or side effects or downsides of this treatment, if you like?
I'm not an expert in TMS, but as far as I understand, there are no major side effects coming out of TMS treatments. It's basically pain at the site when you're actually doing the stimulation. In some studies, headaches. I believe you still have the hypomanic switch, but to a lesser extent than what you have with an antidepressant.
So the risk of a depressed person going into a hypomanic episode.
Exactly. But that's for TMS. That has not been shown for TDCS that we're using.
So the main reason why TDCS is advantageous over TMS is because it can be delivered at home, it can be delivered without supervision. Is that right? Is that the main advantage?
Yes. One of the main advantages of TDCS is that it can be delivered at home. Flow is intended as a first line of treatment for major depressive disorder, including for treatment-resistant patients in the EU, UK, Brazil, and a few other countries. And TMS is normally used for severely depressed, treatment-resistant patients only.
Right. Okay, that's helpful to know. I didn't understand that. So you guys are making products that deliver TDCS. How many different products do you make?
We only make one product, and its indication for use is in the European Union, in the UK, Brazil, and so on. It's a treatment for unipolar or MDD, basically, unipolar depression.
How difficult was it to study this and research it and show, how beneficial it was?
Oh, it's quite difficult. And I would say that the difficulty lies mostly with the disease. So we know, for example, from pharmaceutical studies that around 50% of, I believe, the phase 3 studies, or if it's all studies, fail. And it's not necessarily because they don't have an effect, but more like it's very difficult to control the placebo effect in these trials. So you need to be certain or good with controlling that and the blinding in order to actually show separation between the groups if you're doing a placebo-controlled trial. So that's a difficulty in itself. Then I wouldn't say it's particularly difficult in doing trials with these types of devices. Our specific device, as you mentioned before, is made for home use, which means that it's quite easy to do these decentralized trials where you have maybe one center and one principal investigator and a couple of clinicians that are doing telehealth, assessing the patient, whether they have the diagnosis and so on, everything that goes into doing a trial. And then you could send them the device, and then the patient can do the treatment at home, which means that you can recruit from all over the country. For example, we did it in the UK and in Texas, and then you can recruit from all over Texas and all over the UK, which helps with recruitment rates and so on.
So when you said earlier that there were trials that failed, does that mean failure to distinguish placebo from therapeutic effect of the device, or was it just that the device wasn't showing benefit?
So what I was referring to was antidepressant trials, so pharma trials, and those fail in 50% of cases. But you can generalize, I think, from those types of trials and say that these are trials on pharmaceuticals for depression. And depression is very difficult to do a science on. So I think it applies on our field also, that it is quite difficult to get this separation. It's difficult to understand sometimes what the effect sizes will actually be and how you need to power the studies and so on, and actually to find the effect.
Yeah. Anya?
I mean, what you touch on is within the TDCS field, there's been quite a variability in terms of what studies have shown. And the trial, the sort of the big trial that Flow has been used and had quite positive results, but that's not necessarily, there's a lot of variability then in the field with other trials that have been done as well, right?
That's true. There's been other trials that have failed. What I would add is that TDCS is not a uniform kind of way of approaching. It's not like saying we're going to run a trial on escitalopram, 100 milligrams, moderate to severe depression, and then try to replicate that, and then some fail and some work. It's not like that. TDCS, of course, can come in different forms. We know that if you have a certain dosage, you won't reach patients. Now, the standard protocol is 2.0 milliamps, so most people are using that. But of course, it differs if you have a larger or a smaller electrode. The current becomes more focal. You have a more focal stimulation. And then you can deliver many sessions over a longer period of time in order to get this separation of the placebo, because the placebo often comes down after 4 to 6 weeks in effect. And so there are many different parameters that goes into it. So if you say that one trial failed, it could very well, and we believe that we have a good understanding of this, that it failed because of very specific reasons, and not because, we just raise our hands in the air and say, we have no idea. It's just TDCS.
So that's actually helpful for me to ask about. So when people buy the product, are they instructed to use it in a very specific way? Do they have one protocol they're instructed to use, or do they have a choice between different protocols?
So if we're talking about our specific product, that's a very specific protocol. And of course, the trial that was done, that was published in Nature Medicine now in October of last year, that had, of course, our equipment, our specific pad sizes and so on, and used a program that was 36 sessions over 10 weeks, placebo-controlled trial. And that's the standard protocol. Then we have also a clinician platform, to call it, and that's basically a web interface for the clinician to follow, monitor their patients. And in that case, you can also change the stimulation protocol. So if there is, for example, a patient that needs more stimulation sessions because of severity, or like a high severity of depression, or a very chronic disease type, then they would go more sessions, for example. So standard protocol, that's for the standard product, and then with the clinician you can change that.
Okay, that's helpful. And so the standard protocol, how often are people doing sessions, and how long are the sessions?
In the EU now, they're doing 30-minute sessions 5 times per week for the first 3 weeks. And then after that, you move on to 2 times per week. Now, in the study, it was very similar, but instead of 2 times per week, it was 3 times per week for the remaining 7 weeks. And that will also be changed now, but it has to do with regulation and how you present data and so on, where we can now change the protocol to these 3 weeks. But it's not a big difference, but that will be the standard protocol, yes.
And so in the Nature study, which was sponsored by Flow, the patients were essentially followed up over a duration of 10 weeks, is that right?
So the blinded phase was 10 weeks. And then there was an additional 10 weeks as an open label, where the people that were in the sham group could switch over to active group, obviously, as an open label, and the ones in the active group could continue. So we have relapse rates, we have switching rates between the groups, and then we also had a follow-up at, I believe, 11 months after the enrollment. That was also published.
And what were the results of the Nature study?
So for the 10 weeks blinded, you had 3 different questionnaires. You had the Hamilton 17. You had the Madras and the Madrasas.
Just so listeners know, the Hamilton and the Madras are like questionnaires researchers ask patients in trials to kind of rate like how severe are the depressive symptoms.
Exactly. So the first 2 I mentioned, that's the clinician that rates the depression severity. And then you have the Madras S, which is the patient answering the questions themselves. And in the Hamilton, you had roughly, I believe, 58% that went into remission after 10 weeks, meaning that they're out of depression, versus in the sham group around 30%. And that pattern was the same in all the different instruments. That is roughly 2x on the response and remission rates in the active group versus the sham group.
And that's definitely interesting quantitative data. I was wondering if you guys collected any qualitative data at all, any data just like about how people were feeling subjectively and their experiences on the treatment.
So we collected some data on, obviously that had to do with or a lot of safety data, but that were qualitative. So they could describe, for example, how they felt about the stimulation and so on. But normally you would like, in these types of trials at least, we have other trials from within the NHS that were more qualitative that we can talk about. But in this trial, it was important that we use standardized questionnaires, standardized scales, so that we can report quantitative numbers, because normally that's what the regulator is looking at. That's what, in many ways, the payer is looking at. So you need to be able to show it and in order to benchmark it and so on. It's quite difficult with qualitative data.
The trial we just talked about came out in Nature. That was in October 2024. There are a couple of other papers which come up quite a lot when we're talking about TDCS, and I will put all these papers in the description, listeners, so why not? One of them came out in The Lancet in August 2023, and another one came out in JAMA in January 2024. And these didn't really seem to show much effectiveness of TDCS treatments in terms of treating depression. Can you comment on these studies? Do you have any issues with these studies, or how they could have been done differently, or why perhaps they didn't show a benefit with TDCS treatment?
Yeah, we have issues with them. With that said, we haven't done the studies, so we only have access to the data that is published. But there are differences, as I mentioned before, differences in the equipment. There are differences in the amount of stimulation sessions. And there are slight differences in the populations. So some of them had more treatment-resistant patients in their patient population. In general, I would say that, but of course I would say that, but we're very comfortable with the claims that we are making in relation to our study. As I said, there are many parameters that can change along the way. So the only way to really do this, if I'm allowed to say that, is basically to say this is what we claim and this is our study to support it. Then there are many other ways of doing it, and we can't really. I can have a discussion about it, but I'm not really. Yeah, those are not our studies, basically.
I guess one thing, I mean, coming back to the Flow study and sort of some of the data that you have from, I guess, qualitative as well, but I'm curious about, I think you collect real world data just from people using, sort of all the people that have purchased and used the device. I mean, so in the study data, I guess one thing that jumps out to me is the sort of the level of education, and from that I infer possibly the socioeconomic status of participants. And it makes me wonder how reflective that is of patient populations that we may see, certainly within sort of secondary and tertiary care psychiatry, but even arguably, at GP level populations. I guess I wonder what your thoughts are on that, and also whether your real world data differs from the sort of, highly sort of PhD level education people that were a large part of the participants in the clinical trial.
Yeah, I believe I looked at this specifically the other day, and I believe that PhD level, weren't that many who were on PhD level, right? It was master level and bachelor were the big part, and then you had below that was around 20%, if I remember. So we shouldn't exaggerate it.
But even the bachelor and...
Sure, that's not representative of maybe the big group. So yeah, it depends on how you see it, of course. So it would be a lot easier to treat patients that are more highly educated. I'm not sure I have any empirical data on whether that's the case or not. I know, of course, that the numbers go up in people that are less educated, but whether they are more treatment resistant, I'm not sure about that in this type of treatment or when it comes to a pharma. But I would also say that, I mean, the evidence comes in packages. If you only look at as one study and say, okay, it's based on that and that's it, then maybe I would agree that that would be problematic. In our case, we have that study, we have additional, I think, 7 studies published from within the NHS on very difficult to treat patients, severely depressed patients, treatment-resistant patients, and so on, that are not double-blinded, but that show reasonably good results in comparison. And then, of course, the real-world data is around 50,000 patients, and there it's less controlled. But on the other hand, the numbers are fairly good for being such a diverse population with a lot of comorbidities. I think our estimate is around 50% treatment resistant based on what they have told us and based on what we kind of can assume from proxy questions and so on. So it's a package of evidence that, and then of course you could say, how effective should a treatment be in order for it to be called a treatment? And that's another discussion that could be had.
I guess I'm curious in terms of following up, I mean, that's obviously phenomenal sort of amounts of real world data, which is amazing that you guys have that. And I'd be really curious to hear more of your insights again about the diversity of patients. You know, the fact that you say that 50% of them are treatment resistant is, again, very, very different from the trial population, which excluded people.
Sure. Our EU and UK licenses are based on a wider evidence package than the Nature paper alone. So that includes the Empower trial, which enrolled patients who had failed at least one antidepressant. It also included post-market surveillance on more than 50,000 users since approval in 2019, and NHS studies in difficult-to-treat depression. So that totality of evidence was reviewed by our notified body and underpins our indication for major depressive disorder, both non-treatment resistant and treatment resistant. So while the Nature trial excluded treatment-resistant patients, we believe that the real-world and clinical data supports flow use in that group.
Yeah, it must be really tough because science is all about like nuance and the fine print, and everyone I know that's in marketing is all about like simple. Your message has to be simple and consistent. So I imagine this is like a big source of tension for you guys, where you have to, obviously you want to market your product, you want to be successful, but at the same time, you know, you have the responsibility and you want to communicate the ins and outs of the science in a way that's responsible. Is this something you guys spend much time deliberating over?
Oh, yes, definitely. And have from the very beginning. It's been very important for us to back everything that we say up with science. I mean, both of the founders are extremely, I would say, if I'm putting it in a slightly negative way, but skeptical people. And you need to be able to back up with in a reasonable way what you're saying. With that said, I mean, you also have to look at what's perfect in an academic setting, for example, where you probably would say that you never know anything. And then there is the practical reality where you also have to see, can we make an impact? Can we deliver something to many people that will have a net very positive effect and reduce the safety issues to the very minimum? That's the practical reality. And that needs to be considered also, because if you were to move in this like perfect direction where everything needs to be known to, I mean, you could do studies on thousands and thousands of patients just to increase that last statistical knowledge around a problem. You would probably never build any products and do anything. And so that's a balance. With that said, I feel very, very comfortable. And of course I will say this because I'm the owner of the company, but I feel very comfortable about definitely the safety and also the efficacy. But it took a while. And I would say that the study that came out was the point where the founders felt that, okay, this is really real, this effect.
And are there any risks, downsides, side effects patients should be aware of? Are there any medications that a person can't take if they're using the headset, anything like that?
Yeah, I would refer to the IFU for that specific list, but there are medications that would reduce the effect of the treatments. One example is benzodiazepines. Now, with that said, it's not a contraindication, so it's not something that would increase the risk of the treatment, but it would potentially, there are some indications in the literature that would decrease the effect, which is bad enough. And then there are things that has to do with reconstructive work in the brain at the site that would be up to the psychiatrist or the neurosurgeon to decide whether that is still reasonable to use the treatment.
And any side effects or, physical risks of just getting the treatment itself?
So what we showed in the study, and there you look at the difference between the active group and the sham group. You have for example, I believe around 20-25% prevalence of headaches, for example, in the active group, but you also have that in the sham group, which means that doesn't come out as an effect of the active treatment. But you have skin conditions.
I guess it suggests the headaches could be a nocebo, the opposite of a placebo.
But you have dry skin, for example, and in the study there was also a statistical significance between trouble concentrating, mild case, but still there was a difference between the groups. So skin conditions is the most, that's the one that have popped out in that study.
And is there anything, among different TDCS treatments, is there anything that makes the Flow headset unique or uniquely efficacious?
So I would say that the thing that I mentioned before about electrode size, the particular protocol, I mean, using 2.0 milliamps, but in a more focal way, our specific positioning. But then it's also more of a product package that you can use the device in a safe way because we control the protocol and how many sessions the user can use. So there are a bunch of things in there. But if you're just talking about the headset, I would point at positioning and electrode size and the amount of stimulation sessions for this particular patient group.
Are there any research questions you guys are still working on? Are there future studies being planned to get more data on the use of these headsets?
Oh yes, absolutely. So we have several studies ongoing. I can't go into detail on these, but there are a couple of NIHR-funded studies on unipolar, on bipolar, other age groups, and there are studies on, let's say, being a little bit more specific on who you should treat with the help of biomarkers and so on. So that's an area that I think is very interesting in order to increase the effect sizes and be more specific about who's going to respond to treatment.
Yeah, I think that could be really interesting. I mean, clinicians in psychiatry often feel that what we kind of refer to as one condition now, let's say depression or bipolar or even ADHD, something like that, might actually represent groups of conditions, different subtypes, which, at the brain level, there might be very different things going on. Could very well be the case that in depression, we might have a specific subset of people with whom there is this, specific part of the brain, the left dorsolateral prefrontal cortex, that's underactive, and maybe that's the patients for whom this headset will really work. And then there might be other patients where something entirely different is going on. So anything that can shed light on that.
Exactly, and I think it looks like the effect sizes are similar, at least for different types of antidepressants. TMS is a little bit different because it's different populations and so on, but that they have examined. But I would say that I strongly believe that the future is not that someone comes up with a solution that treats everyone, if that's even possible, but more like you have this combination of different tools and you choose them based on a very good predictor mechanism of some sort.
Yeah, I mean, I think it's amazing that you guys are running these studies as well to look at potential predictors and biomarkers, because I mean, I completely agree with what you both have said, that feels like we have so many different treatments now, but what we lack is kind of the ability to judge which patients might benefit more from them. And my mind immediately went to a study that was done of combining TMS with CBT, which came out a few years ago. And I don't know if it's one that you're familiar with, but and I don't remember the sort of full specific details, but the long and short of it was that whilst there wasn't a specific effect of TMS enhancing the effects of CBT, so cognitive behavioural therapy, the sort of the most common form of psychological therapy that's at least used within the UK, what they did find actually is that the subgroup of patients that had the lowest levels of activity as measured by an MRI scan, and who then increased that level of brain activity in response to the TMS, actually for those patients there was a benefit of the combination treatments. And I guess I don't know if you have a sense for that for TDCS in terms of any of the work that you guys have done or that's already been done, or what your thoughts might be on which subgroups it might be that you're looking at.
I think it's very difficult actually to see that in the data. We obviously have this very large pool of real world patients where we try to ask questions if the user is willing to answer it in order to try and do these categorizations. And so far it's been quite difficult just based on questions. So all of these usual suspects that we have, treatment resistance being the major one, previous treatments is a good predictor, I guess, of future success. But otherwise it's very difficult to tell. So my best guess is on biomarkers instead, and seeing specifically, how that specific type of brain, sloppy wording, but that specific type of brain would react to this specific type of stimulation. Measured by a biomarker of some sort. If it's genetic or if it's EEG or FNIRS or something like that, I'm not sure what the outcome will be. But that's my best guess, because we haven't really found it correlated with any type of question that we can ask. In my view of the literature.
And that would be what I want to say next, which is what are the key questions you want to answer, say, in the next few years with regards to Flow and the headset? What are the questions you would most prioritize getting data to try and address?
That specific question, who responds? Who
responds and why?
Yeah, well, why? I mean, why? There is some kind of why, but I don't think we are a company that is very focused on getting treatment out to patients. And you have touched upon it with your questions a little bit, like what's reasonable, what type of messaging can you get out there, what, shouldn't we be more careful, is what I'm kind of reading between the lines here. And I think that the ethos of the company is to deliver a safe treatment to the many. And if you're going to do that, I think that we need a little bit different of an approach than what we have had in the past. And I think we see it a little bit in the UK with, for example, the Aya, or whatever it's called now, the talking therapies, where they, as I understand it, more go on symptoms. You measure symptoms rather than doing a full diagnosis in order to treat the many. And I think it's actually a very good approach. Because otherwise, you just throw your hands up in the air and you say, we should do it the way we have done it, but we can only treat, 30% of the people that need it. And I think that needs to go into the calculation. So to answer your question, to find out very specifically who is going to respond, so that you don't promise anyone that something is going to happen. Even if we are very clear, I believe, that it only works for a certain amount of people, and those numbers are hopefully very clear, you could still be much more precise with this type of measurement in the future. And I don't think it's that far away. We're talking maybe 1-2 years before that's possible. I mean, you can always talk about, okay, on what accuracy level and what type of, how effective should it be? before you say that it's going to work and so on. There are always details in it, but I think we can do significantly better than what we have done in the past 50 years with being precise with the patients and not leave it up to in what type of training the clinician or the psychologist have.
Yeah. No, I think I'm totally on board with you with the pragmatism of it. I guess when I say let's find out who it works for and why, the and why part for me is more about because it just sheds light more on the nature of depression and also will help to inform new treatments, better treatments, which I'm sure you guys are interested in as well. I'd be really curious to know, over the time that you've worked with Flow and developing this technology, has it changed your view of what depression is at all?
Of course it has. I think that the basics were there from the beginning, treating patients and doing the education. But I now, not fully maybe, but I do understand a lot better that it's a very heterogeneous disease and that people can have very different symptoms and be presented in different ways. I understand that these questionnaires that we measure it with, the severity questionnaires, are very different and they measure different things. And you can get very different results based on what you ask, even though they're supposed to measure the same thing. And a patient that has 12 on the MADRS and another patient who has 12 on the MADRS, it could be very, very different in severity also. And I mean, one could work and the other one could be totally out. So that is very important, of course, that we go beneath. It's one thing to talk about numbers. When you meet someone, that's a totally different story, of course. I mean, as a psychologist, I'm trained in connecting deeply to those symptoms and trying to understand them on a very personal level and show the empathy and everything. But I felt that I needed to take an outside perspective, zoom out in order to address it for the many again. So that's why I kind of become a little bit more quantified, if that's the right word.
Yeah, that makes sense. When it comes to research, quantity helps you with large numbers. Qualitative data helps you understand, the individual and subjectivity. And, I study psychotherapy, so we work a lot with qualitative data and psychotherapy. And that's why I'd love to see some mixed data research that kind of sees if we can, examine both, get data on both, and see if we can draw any correlations. When I talked to Nolan Williams, so Nolan Williams is a psychiatrist at Stanford. He's done a lot of work with quite intensive magnetic stimulation treatments. And I don't know if this was a formal qualitative study that he did, but he talked about how as patients improved with magnetic stimulation, it wasn't just low mood just goes away. But he describes people did change psychologically in quite meaningful ways. They would, all of a sudden start to see choices that they had that somehow they were blind to before. They might be driving home from work and say, oh, actually, I could stop at the beach and I could enjoy myself on the beach. I don't have to, just go straight home. All of a sudden, new choices emerge and somehow that correlates with the lifting of the mood. So it would be really cool to see if there were studies in the future which kind of gets a flavor of both worlds, if you like.
Yeah, and as I mentioned before, we have a couple of those, I think 2 from within the NHS in these more severely depressed patients. But I think when you mention that, I also think it's very interesting. And of course, if we talk about what we as a company are doing in order to understand our patients, customers, users, it is often through the support channels. So we have a lot of internal data going back and forth together with our support, but also with reviews, obviously. We never pay for reviews. We only ask that people, if they have a bad experience, if they have a good experience, to share the information because it could be helpful for others. We have a forum on Facebook. I think there are 10,000 patients there or something like that discuss their experiences. And that's also qualitative information that we cannot really share in this forum what those conclusions are, but it's open for everyone to look at, of course.
Yeah, and obviously if there is negative information, that's something you want to know, because ultimately that's going to help you make the product better.
Oh, of course. And we also have to report it, because we're a medical device company. We have to report it to the authorities. We have to, every year, we have to put it together in a report. We have to draw conclusions from it in a systematic way, and we have to send it in.
Outside of brain stimulation, are there any emerging treatments in the mental health world you're excited about right now?
Yeah, I mean, there's always the psychedelics that are interesting and that makes a lot of buzz. I'm not super impressed when you actually go into the details of these studies, and it has to do with placebo effect. It has to do with all these different things that made the FDA, for example, not approve, I can't remember the substance now, but was it MDMA for PTSD? Yeah. So they had a problem with selection bias in the studies and the way it was conducted and so on. And so I think that might become a problem with what I know from our studies, that you need to be able to have a very firm understanding of the placebo. And but there are ways around it, and I think they will get there. So for the severe cases, severely depressed patients, I would say that's very interesting. Ketamine, I don't know that much about. I've heard that there are studies that look good, but I'm not super convinced. But I'm not an expert in that. Then there are a little bit more far out mixes of things where you combine brain stimulation with plasticity enhancing drugs. That looks also very interesting. We have a collaboration with someone or a very early stage at Georgetown, for example, looking at that. That could be very interesting. So I'm more, what I'm trying to say is I'm more of a believer in this precision combination approaches rather than like, okay, this is the solution.
Right, rather than find the miracle cure.
Yeah.
I'd love, Daniel, to know your thoughts on the potential for combination therapies, so between TDCS and psychological therapies, whether this is something you're thinking about.
I am thinking about it. I mean, obviously I am a psychologist, so it's not like I've thrown that out in any way. I still believe in the psychotherapeutic process and so on. So like the company was started with the idea that you would have this headset that would give the user, for the lack of better words, a boost in energy first. And then we added on behavioral therapy or a certain digital type of behavioral therapy in the form of this app where we teach the patients how to understand depression and also what they can do themselves in order to decrease the symptoms. So I do believe in that. Whether the TDCS can enhance the effect of a psychotherapy, I'm unsure about it. There's been some studies looking at it and they haven't shown really great results. But as I said before, it could be a lot about the parameters used. So I do believe, but it's also about the effect sizes and if you stack treatments on top of each other, how do you actually show compared to a placebo that it actually works? It's not like you can of course get great response and remission rates in an open label trial or just an active treatment. But if you're going to compare it to a placebo, you need to get the design right. And that's why I'm a little bit hesitant to say that, okay, it's going to come out fantastic. With those caveats, I obviously believe in both treatments and that they can be enhancing each other.
Yeah, so again, there's this tension between, okay, understanding something is likely to work, likely to be a feasible and a good idea versus, it can be really, really difficult to prove something scientifically. So the research is going to require a lot of planning and a lot of meticulousness.
Yeah, and a really big M. And then you have the discussion about clinical significance, like how big of an effect does it have to be, even if you find statistical significance in a group of 1,000, which no one would ever run a trial like that because it's so costly. But maybe in the future there are other ways of approaching it with its decentralized trials and so on, where you can pool data from different countries and stuff like that, where you could show it.
And in terms of future research studies that you do on Flow, when they come out, do send them our way. Anya and I do discuss research papers on the podcast. We'd be happy to receive it and look at it and see, what kind of results you guys are getting. It sounds like you guys are doing really good work. Thank you so much for coming on and spending some time with us today, Daniel and Anya. Thank you.
Thank you so much, guys.